Good evening and welcome to the second in series of American College of Surgeons webinars sponsored by the Practice Protection Committee. Tonight's topics will focus on three areas: contractual considerations, hospital relations, and an update on financial resources that are available for surgeons. I am Pat Bailey, Medical Director for Advocacy in the DC office of the American College of Surgeons. Thank you for joining us. I'd like to now turn to Dr. David Hoyt for some opening remarks. Dr. Hoyt.
Thanks, Patrick, and thank you all for joining. We know this has been a particularly challenging time, and the webinar tonight brings you a number of people to help you think through some of the issues that are facing you in practice. We spent the last webinar talking about people in particular in small private practice, and tonight's really focused on those of you that are in contractual relationships with hospitals, either employed or in part of academic medical centers, and we have a great panel that's been put together by Patrick to discuss that. So with no further ado, thanks, Patrick.
Thank you, Dr. Hoyt. Also joining us tonight are members of the Practice Protection Committee, and they'll be available to answer your questions during the Q&A portion of our program. We are also pleased to have with us as presenters and participants Stacy Cook, partner at the law firm of Barnes and Thornburgh, former chairs of the Board of Regents Mike Zinner and Julie Freischlag, as well as Mr. Peter Austin, who is the Chief Operating Officer of the Jefferson Regional Medical Center in Pine Bluff, Arkansas. As was the case in the previous webinar that we did, I'm going to throw a lot of information at you relative to the financial resources in a very brief period of time, but I want to assure you that there are three sources where you can go to review this information. Number one, this webinar is being recorded and it will be posted. Number two, the previous webinar that we did is already posted and available. And thirdly, the Practice Protection Committee's resource document, which was prepared and updated this past Friday, is attached to Friday's ACS COVID-19 newsletter. You will note in the presentation, though, that some changes have occurred over the weekend, and I will highlight those as we go forward. The financial resources available to surgeons during this time basically fall into three categories: grants, advances, and loans. With regards to the grants, there was initially $100 billion from the CARES Act put into the Public Health and Social Services Emergency Fund. This was supplemented last week with an additional $75 billion. Of those funds, $30 billion were dispersed on April the 10th, and $20 billion began to be dispersed this past Friday. The dispersal of the $30 billion was based on your 2019 Medicare receipts, with the conversion factor being 6.1%. The dispersal of the $20 billion is issued in such a way that the entire $50 billion that's going out will be allocated proportional to individual providers' share of their 2018 net patient revenue. Now, you'll remember that previously there was some concern that a lot of this fund was disproportionately sent to Medicare-only providers, or providers that had a large portion of receipts in Medicare. And the intent here is to make the distribution more equitable for those who receive a higher portion of their receipts from sources other than Medicare. With regards to that first round of funding, no action was necessary. It was deposited in your account based on your taxpayer identification number. Again, these are grants, they are not loans. However, and this is becoming increasingly more important the more we learn about the second dispersal, attestation is required. It must be done within 30 days, and you are attesting to the terms and conditions attached to the funds. This slide summarizes and has a lot of information on it about that first dispersal, when it went out, the dates for attestation, when it is required, and the links to attest. Again, this webinar will be posted. These links will be available to you for you to complete that attestation, or using the same portal, you can return the funds. If you do not take any action, you will be viewed as having accepted the funds as well as the terms and conditions. Any questions on this, we refer you to the CARES Provider Relief Line, 866-569-3522. With regards to the second dispersal, it started on Friday, and the information that we're giving you is as of Monday afternoon, Monday evening. It appears that it's particularly important, as I mentioned, to complete this attestation because that is a prerequisite to receiving funds from the second dispersal. To apply for funds for the second round, you will need several pieces of information that you see listed here. Again, the most important thing based on what we know right now is that to receive funds from the second dispersal, you must have already received a provider relief fund payment before 5 p.m. on Friday, April the 24th, and you must have attested to have receiving that payment via the provider attestation portal and agree to the terms and conditions on the portal. The question arises then, what about those who did not receive any funds in the first disbursement? What can they do about applying? Currently, and this will evolve over time as it did with the first dispersal, based on what we know, is that you're best to call the provider relief line there on the screen and ask for further information. Again, we do expect that this is going to evolve and change over time, and this just became live as of Friday afternoon at 5 p.m. Next, we'll move to the advances and the Medicare Advance Payments Program. This was also changed since Friday. This program allowed you to apply for 3 months of Medicare payments in advance. That was essentially a loan against your future Medicare claims. This program was abruptly suspended on Sunday, yesterday. Over the course of this program, since its inception on March the 30th, it has dispersed $100 billion in payments, with $40 billion of those payments going to Part B suppliers. There are 2 loan programs that are still out there and have both been replenished that we'll go through quickly. The Paycheck Protection Program. Key things to remember about this program is that you apply via your local bank or Small Business Administration approved lender. This application does not go through the SBA itself. It is limited to entities with 500 or fewer employees. And what makes this program so popular is that it has loan forgiveness provisions. The loan amount that you can receive is 2 months of average monthly payroll costs from the past 12 months, plus an additional 25%. But it should be noted that the annual salary cap for purposes of calculating your monthly payroll cost is $100,000 per year. This application is reported to be very complex, and it requires information that you likely do not have readily on hand. You are urged to enlist the services of your financial or professional tax advisor for the application process to facilitate it. The intent of this loan program is to maintain operations and to keep your staff on payroll. The loan forgiveness provisions themselves are based on the use of the funds for allowable purposes. Those include payroll, your mortgage interest, rent, and utilities. You will have to have accurate records to qualify for the loan forgiveness, and so you will need to keep those records going forward. As you may have heard in the news, very much out there in the popular press, the initial funding for this program was expended on April the 16th, at $349 billion. It was replenished last week with an additional $321 billion, with $60 billion set aside for small and medium-sized financial institutions. We urge you to apply as soon as possible, and engage your professional tax advisor to assist with the application process. Lastly, we'll just mention the economic injury disaster loans. As opposed to the PPP, this application goes directly through the SBA, not through your local bank. It is, however, also limited to 500 or fewer employees. These are loans. They have very favorable terms, but they are not forgiven. You can apply for a loan amount up to $2 million. The initial funding of this program was also expended on April the 16th, but was replenished last week with an additional $60 billion, with $10 billion of that being set aside for individual $10,000 rapid advances. Once again, the application for this is through the SBA website. All the links for that are available on the Practice Protection Committee's resource document, which was attached to Friday's newsletter and will be available again and with additional newsletters coming forward in the week. With that, I will turn it over to Stacy Cook from Barnes and Thornburgh for our discussion of contractual considerations.
Thank you, Dr. Bailey. Hello, everyone. Again, my name is Stacy Cook. I'm a healthcare attorney representing primarily healthcare providers. I'm a partner at the law firm of Barnes and Thornburgh here in our Indianapolis office. I'm pleased to be with you tonight to cover the topic of contractual considerations. And I'm going to launch right in so we can cover as much ground as possible. I'm really going to talk about three topics for those employees who have written contracts with their employer. And the first is, how does your contract fit with your employment relationship specifically? When can your employer end your employment relationship? And how can your compensation be changed? And then the second topic I'm going to cover is certain terms in your contract that I would suggest you review and be prepared if you are anticipating that your employer might want to or need to either terminate your relationship or at least renegotiate certain provisions in light of the pandemic. And then finally, I'm going to provide you with a couple of things I think you should be thinking about to prepare yourself in the event, again, you're in the position of needing to renegotiate certain provisions of your contract. As a reminder, while I am an attorney, keep in mind that my presentation here is for information only. It's for discussion purposes, and it is not to be considered providing you legal advice, because of course, as you know, I don't even know all the people who are on the call. I don't know your specific situation. And so it can't be considered legal advice. I would definitely encourage you to seek competent legal counsel if you have specific questions, but certainly we can have a good, lively discussion today about these contract issues. So first, how does your contract fit with your employment relationship? You are an employee, but generally employment law is based in state law. There are some federal laws that also govern employment. But if you have a contract, like most physicians do, your contract is going to be really the main focus of the terms of your relationship. So if we look at how that compares to an employee without a contract, in most states, our employees are considered at will, which means the employer can terminate them for just about any reason. The only limitation is they can't discriminate against them based on gender, race, those types of things. But the employer in an at-will relationship can terminate the employee for any reason at any time. So they can decide, tomorrow I don't want you to show up to work because I just decided that I don't want you to work for me anymore. No notice is required. They can lay off employees, they can furlough employees, that type of thing. Wide range of options. However, if you have a contract, your contract will dictate when your employer can terminate the relationship. So we had a question come already asking, can an employer furlough surgeons that are salaried and have a contract? And my general answer to that would be no, if the contract doesn't permit them to do that. So how does a contract typically speak to when the employer can terminate the relationship? There are typically three areas. The first is typically the most obvious and the most direct way. In every employment contract that I've seen with the physician, there is a specific section, and this is common in all contracts, that's usually titled Term and Termination. And that whole section or paragraph will cover when does the contract start and when does the contract end. Usually the ending date is measured in terms of years typically, or months, like it's a year, 18 months, 2 years, and so forth. But almost always there's also a provision that says that the employer, and sometimes the employee, but let's focus on the employer here, when the employer can terminate the contract early. And usually that's split into for cause. In other words, the surgeon does something quote unquote wrong, like if they lose their medical license, that would be a reason to terminate. And usually there's a whole section on when the employer can terminate without cause. And typically that just says the employer can terminate without cause by giving notice within X number of days. Back in the day, physician employment contracts usually had a real term. It would be, we agreed to enter into this contract for 4 years, and the only way we can terminate it is if someone breaches the contract. That is not the reality today in the vast majority of physician contracts that I see for my clients. Usually the contracts allow an easy out, and usually it's 90 days. So it'll say the employer can terminate without cause within 90 days. So in essence, you have a 90-day contract. So that's the first place you'll want to look when you're thinking about how can my employer terminate my employment relationship. The second way in a contract that's usually found in a contract, if it doesn't have a without cause provision, or for example, if the without cause provision is a year, that the employer has to give 6 months or a year notice, you could have a provision in your contract that's called a force majeure provision. It's a French term that literally translates to superior force. You may or may not have this in your contract, but the intent of this, and they're very common in many contracts, is to say that one or more of the parties is excused from having to perform their obligations if there are forces beyond their control that prevent them from performing those obligations. Usually those are tied to natural events such as hurricanes or tornadoes. And so typically those say if there's an act of God beyond my control, like a tornado, and our hospital is demolished, I'm not able to perform the contract, so therefore I'm excused from performing the obligations, which would be usually providing you a place to perform surgery, providing you a salary. Whether or not a force majeure clause will apply in the COVID-19 pandemic depends specifically on the language in your contract. So it doesn't automatically give your employer an out. It really depends on how broadly the language is drafted. And third, and I'm going to touch upon this really quickly, your employer, depending on the state that you're in, may be able to argue outside of the four corners of the contract that if it is impossible for your employer to fulfill its obligation, then it should be excused from the contract. And I can see where employers may argue, for example, if the governor has issued an executive order that prohibits elective surgeries, a hospital may argue that it is impossible for it to fulfill its obligation, and therefore the hospital may argue it's able to get out of your contract. The second point in your relationship is how and when could an employer change your salary, decrease your salary? And again, for employees that do not have contracts, Employers can do this at will. They can just say, tomorrow I'm going to pay you less. And the employee really has no recourse. However, again, if you have a contract, the terms of the contract dictate. And so the employer must follow what it says in the contract. And typically, and so again, we had a question come through, can an employer decrease your salary? Wouldn't that be constitute? Oh, I think somebody's not on mute there. That wasn't me. So anyway, we'll keep going. We had a question come through, can the employer decrease your salary? Wouldn't that constitute a breach of contract? And my answer to that is it depends on what your contract says. I usually see two areas where compensation can be flexible in a contract. The first one is, of course, productivity, or if you have a compensation methodology that is tied to productivity, which most physicians do nowadays. The other way would be if there's other language in the contract that gives the employer flexibility. Unfortunately, I see many times that hospitals try to stick language in the contract that gives them flexibility. And it can be as briefly as saying something like something, excuse me, we're getting some feedback still, sorry about that, or someone who's not muted. So for example, the contract could say, your compensation physician is as set forth in Exhibit 1, which is a compensation methodology, and it may then say, which the employer can change from time to time. Just that small phrase would arguably give your employer the ability to change your compensation. As you can imagine, words are extremely important, which is why we try to have a meeting of the minds in the contract. So if you are trying to anticipate whether your employer can change your salary, your compensation, look at your contract or have your attorney look at your contract very closely to see if there's an out in there for your employer. The second topic I want to cover are just a couple of terms you should be aware of in your contract and look at closely if you're anticipating that you may be terminated or may need to renegotiate your contract, and that is your non-compete clause. We get the question, if I am let go or terminated under my contract without cause because of this pandemic, in other words, I didn't do anything wrong, does that have any effect on my non-compete clause? In other words, will I still be bound by my non-compete? And the answer to that is, again, it depends on the language in your contract. There's no one set paragraph of a non-compete. It's completely how the attorneys draft it and how you negotiate it. I will tell you, in my experience, I would say that 80% of the contracts I see are drafted, I'm sure this comes as no surprise to you, in favor of the hospital or the employer. And most of the contracts I see will say the non-compete applies when the contract ends, regardless of the reason that the contract ends. I will also say that when I represent clients, this is the number one thing I mention to clients to try to negotiate, because I think at the very least in a non-compete, a physician should not be stuck with a non-compete if they are terminated for something that is beyond their control, like this pandemic, or if the hospital simply decides not to renew your contract. So again, whether you're going to be bound by a non-compete depends on what your contract says. If it's not favorable, hopefully you can renegotiate that. Then the next thing you might want to look at is your malpractice insurance. If you have a claims-made policy, your coverage will end when your employment ends, and that means if someone files a malpractice claim against you after your employment ends, you will not be covered unless a tail policy is purchased. So take a look at your contract, and hopefully it says who pays for the tail coverage, and hopefully it says that your employer does. If it does not say that, then I would try to negotiate that as soon as you can. If it is silent, then your employer would not be legally obligated to do that unless, again, you can negotiate that. And then the last thing I want to touch on before I turn it over is just some general things that you can think about to help you start if you anticipate that you may need to negotiate your contract, either because you might be terminated or because your employer says they're in a tough spot and they need to try to change your compensation. And there are really two big areas to think about when you think about your negotiating power. I mean, that's really the first step that you want to do, is think about what negotiating power do I have? What leverage do I have? And really, there are two areas that you should think about. One is, what is the strength of your contract? Do the terms of your contract give you negotiating power? In other words, if you believe your hospital is in a bad spot and they would like to terminate you, or they've come to you and want to reduce your salary, but your contract is very favorable, in other words, the language is good, they can't terminate you for a year and they can't reduce your compensation, then that gives you a lot of leverage, right? You can take them to court, which is going to cost them money. And so perhaps they'll give you a better deal if you're willing to negotiate with them. The second area that you want to look at is, in addition to your contract, what else do you have that your employer needs? So it may be that in the short term, your contract, you don't have a lot of leverage with your contract, but you know that your employer is going to want you to stay on and want you back when all these, governor executive orders are over and they're going to need you back. So maybe your leverage is, okay, you want me, hospital, to give up, X amount of compensation right now. So how are you going to essentially pay me back to make sure I come back and negotiate in that way? So really be thinking about what's your negotiating power and how you can find negotiating power. The last thing to mention is, definitely recommend that you get an attorney if you are negotiating severance agreements or changes to your contracts. And many times I'm asked, how do I find an attorney? And I always recommend to find someone, number one, if possible, in your state because of the specifics of state law. And make sure you get an attorney who has some experience in this area. And usually the best way I find is to contact your state medical association because typically they have good relationships with attorneys who focus on representing physicians, and they can steer you in the right path. And usually they're able to give you 3 or 4 different names. And another way is to talk with colleagues who have had good track records with their lawyers and get recommendations from your colleagues. So with that, Dr. Bailey, I will turn it back over to you and stand by for some questions later.
Great. Thank you very much, Stacy. And as she said, she will be standing by to answer your questions posed during that segment of the presentation. Next, we're going to turn to our hospital relations segment, and we're privileged to have with us 3 distinguished panelists. Former chairs of the Board of Regents, Dr. Michael Zinner and Dr. Julie Freischlag, and then in addition, Mr. Peter Austin from Pine Bluff, Arkansas. We're very pleased that we've got such a breadth of experience here with regards to hospitals and experience in different size hospitals. Both Dr. Zinner, Dr. Freischlag have experience in large academic medical centers. Dr. Zinner currently works in a large community hospital setting, and Mr. Austin is the Chief Operating Officer at Jefferson Regional Medical Center in a town of 45,000 folks, brings that perspective as well. As Ms. Cook mentioned, we've had several questions posed, and we're going to go through some of these here with our hospital relations panelists and get their response to them individually. And we'll start off here with many surgeons went into hospital employment because of safety and downstream revenue sharing. While being employed would seem to reduce financial risk, it has not completely protected surgeons during this crisis. What are you doing in your individual institutions in your attempts to retain surgeons? Dr. Freischlag, would you like to start with that one?
Sure. Can you hear me, Patrick?
Yes. Yes, ma'am.
Yeah. And so what we're doing is to make sure that we protect our surgeons by their base salary, and we're pretty big. We've got 20,000 employees and about 1,800 faculty, 5 hospitals, 3 of which are really rural hospitals. So we're protecting their base salary, even though we can't look at their variable component, but it's about 80% of their salary because we know we're going to need them as we go forward and come back. Because actually we've been fortunate in Western North Carolina. Our COVID-19 burden has been low. We plan on starting elective surgery or scheduled surgery in the week of May 4th. So we really have been trying to keep them here, maintain that, even though they are taking a deficit because of the variable point. We also have decreased salaries of the administration and many other people. All of us are contributing either 25% or 15% of our salary, 25% furlough. So the whole team is coming together, but we know we're going to need them later.
Great. Dr. Zinner, would you care to add or comment?
Well, similarly, we have not changed the compensation for our surgeons. Let me just give you a sense of what I'm talking about. So we're an 11 hospital system that stretches from the Florida Keys to Palm Beach. And we have about 120 surgeons in the system. About 100 of those are in Miami, Miami-Dade County. And much like Julie described, we have a split compensation system with a base plus incentive. And the incentive is either quality-based, small percentage, tiny percent, or productivity. But for us, it's about 65% of total comp is base, and productivity can range anywhere between 30 and 50. As of right now, we have not changed the monthly comp for our individual surgeons because the productivity depends on their RVUs over the year, and the year on their contracts vary from various times. So our hope is that we can maintain as close as we can on a yearly basis to their total comp, but we're also, like everyone else, planning on a recovery phase. Ours probably won't start till the middle of May, or at least hopefully the middle of May, when our governor releases his statewide mandate.
Great. Mr. Austin?
Yes, our efforts have been pretty similar to what you heard about before. Our furlough of employees really went from top to bottom and left to right, including our senior administration here at Jefferson Regional and our middle management. Specifically to our surgeons, they're on, they receive a monthly draw, and then they're paid based on their productivity. They're obviously going to share in a reduction in compensation with the rest of us, just because our volumes have been down. Our hope is that we can get back to work soon. Elective procedures at our facility actually resumed today. Our governor opened the door for that to begin. We'll take some time to build confidence back with patients to come back and have those elective procedures done. So our goal is going to be to work with our surgeons and try to help shepherd them through this. We live in a place that's very difficult to recruit physicians, and so once we get them here, we want to do our best to try to retain them.
Great, thank you very much. I'm going to pose this second question here to Dr. Zinner. Why do hospitals realize losses on physician contracts yet still make considerable downstream revenue, which may not be considered part of that contract's value?
Well, as everyone on this phone call knows, in almost every hospital I've ever been in, the surgeons are and the operating room are basically the engine room that runs the hospital. But what what is rarely discussed is that if that becomes part of your contract, if the downstream revenue becomes part of your contract, that is a per se violation of the Stark law, and the Department of Justice does not look favorably on that. So it really can't be part of your contract. It just acknowledged as a cross-subsidization by specialties.
Great. So our next question has to do with those granted funds from the Public Health and Social Services Emergency Fund. And we're interested to hear from each of you whether or not in your institution any of that money is applicable towards your efforts toward maintaining surgeon employment. Let's start with Dr. Freischlag.
Well, we certainly have received money from the federal government, and we also received money before they terminated the Medicare piece. And actually, I think our state is going to donate money, and that too is going right towards those base salaries and maintaining our surgeons here. So we're using that to keep that going. Now, we're an academic institution big time, and we have people that are not only teaching residents, but medical students, as well as doing research. So part of that is we're looking at all the components of our institution. But sure, we're using all of this to make our whole system stay whole till we can come back to business.
How about you, Mr. Austin in Arkansas?
Yeah, I saw a comment on the chat from someone who was asking about these dollars that are rolling into different facilities. And in our case, we're not receiving much in the way of stimulus dollars. Most of what we're getting, based on what we know today, is going to be through the accelerated payment plan, which I think has been covered here on the previous webinar and tonight. That's those are we'll receive those dollars in advance, but we'll have to pay those back to Medicare. Actual stimulus dollars that we've received have just been a small fraction of what we believe we'll receive in total at this point. Hopefully that changes. But of course, we'll use any dollars that we have to keep surgeons, other physicians that we employ, and we employ a lot, as well as our staff, any expenses that we have to kind of weather this storm because our volumes have taken such a dramatic hit.
Dr. Zinner?
Well, I had this discussion with our system CFO and general counsel and COO just last week. And I was informed by them that for the CARES dollars we've received, that we need to certify that, and this comes from the federal documents, quote, these dollars are to be used to prevent, prepare for, or respond to coronavirus, and quote, only used for healthcare related expenses or lost revenues related to coronavirus. So I said, well, how about loss of employees, compensation for physicians? They said that is not at all clear whether that's allowable or not allowable, and it'll probably take some time to figure that out. Having said that, though, as was just stated by the two previous panelists, you know, the money, it's fungible. So if it's used to, if the money given by the federal government is used to support what was lost, and that's probably going mostly for fixed costs in the hospitals, like 60% is labor, then hopefully our system will be able to support our surgeons and maintain their employment.
Great. Our next question focuses on what sort of things do you all individually think that surgeons can do to help their hospitals and make themselves even more valuable during this time? Let's start with you, Mr. Austin.
Well, a couple of things. So, you know, our surgeons have always been very engaged in what goes on within our hospital. We have one particular surgeon who's on our medical staff today who's actually part of our COVID team. He's also fellowed in critical care, and so he's right there on the front lines. We've got physicians like Dr. Mabry, who's one of our medical directors for our physician network here. And, you know, one of the things he's very helpful with us is as we're planning to get back to work, making sure that we do so in a way that provides for the safety of our patients, sets up a process for surgeons getting back to work and getting their cases submitted and reviewed and approved and put on the schedule. There's likely going to be a prioritization of cases that's going to have to take place within our hospital, so we get those that need to be done first. So be involved, be good ambassadors of your hospital during this time. The general public wants to know, is it safe for us to come and have this procedure done? And our surgeons are going to play a critical role in making sure that's marketing, that's grassroots marketing, but making sure that our patients and the general public feel comfortable and feel safe coming back and having those procedures done, hopefully in the very near future.
Dr. Zinner?
Well, I don't have much to add. I can just say some of our guys are cross-covering in areas like the ICU and the ED and sort of waiting for the recovery phase.
Dr. Freischlag, anything to add?
No, and actually in an academic center, I think raising your hand. I was on a webinar last week with a group of vascular surgeons because I'm a vascular surgeon, and David Rigberg from UCLA said they needed a line service. And for many of us vascular surgeons, the last thing we wanted to do was be called for a line, but they're actually helping putting in central lines and helping manage patients with this disease. In smaller communities, which we have a few here too, you are the ambassador. There are people that don't want to come back to have surgery. So as we participate in how we're going to get them back next week, we are relying on all our surgeons to tell us who needs to have surgery, how we can be in a space that's COVID tested and COVID safe to make that happen. And then for us with teaching, we need to make sure you take care of our surgery residents. They're all very anxious about their training. I have fourth-year medical students that are scared to death, that don't think you're going to want them because they're not going to be able to do interviews with you or do sub-Is with you. So you could help us make sure that the fourth-year medical students who want to be surgeons too, that you can do an online interview, you don't need to see them in person, and that you will give them opportunities. So I think all those things together would be extremely helpful.
Great. In the interest of time, I'm going to skip over to our last question for our hospital relations panelists and ask what sort of preparations that you are making in your hospitals to prepare for a potential second wave of the virus in the fall or the winter. Start with Dr. Zinner.
Well, that has as much to do with what we're planning for the recovery part, which is the changes that are going to occur in certain areas, like medical practice and beds and ICUs and extended hours, COVID positive and negative areas, block versus open booking. Those are things that surgeons need to think about in their practice. And then also the patient experience. I mean, waiting rooms aren't going to look like waiting rooms they were before, not with social distancing. And those kind of policies. So we're preparing really for the reopening as much as we are waiting for the second wave.
Great, Dr. Freischlag?
Yeah, I totally agree with Mike. I think if you don't know how to do a virtual visit, you need to do that. I did a post-op virtual visit, and I just did an initial visit with a physician, actually, Michael, in Miami, who thinks she has thoracic outlet syndrome. And I didn't mind doing it with her because she could actually do her own exam as we were looking at each other. Not every patient can do that. But I think that telehealth, the lack of waiting room issue, trying to figure out exactly who should have operations, how to make that work, looking at what's essential. I don't know what's going on with the second wave. I mean, this virus is very unpredictable as far as when you have it, what happens to you. And so many cities have been devastated by this virus. If you listen to the young woman who committed suicide in New York today, who's an ED physician, listening to Boston in New York, you wouldn't even think it's the same virus that I'm seeing in Winston-Salem. So I think all of us need to take a deep breath, figure out what's the best for patients, making sure that they don't lose their lives to other illnesses, but also making sure that we figure out a pathway forward. And we don't know. I think every morning I wake up, I think, okay, now what are we doing today? And as surgeons, we're pretty good at that, at urgent emergent. The only problem is we don't know what exactly to do. I don't know where to put the clamp, right? So we need to keep having an open mind about where to put the clamp and how to go forward.
Great. Mr. Austin, anything to add?
Not much, honestly. I think that a lot of the things that we've put into place here at our facility will be ways of life for quite some time for us. Things like screening our entryways, screening staff as they come in for work, physicians, patients, tracking COVID patients within our facility, monitoring our inventories and our supplies of PPE, our usage, improving our lab testing capability, enhancing our telehealth efforts. I think all of these things are just going to be part of our way of life for the foreseeable future.
All right, well, that completes our formal portion of our program, and the panelists, the committee, and the ACS staff are now available for your questions that you can type into the text box located on your screen. While we're gathering those questions, I would like to point out that there are two handouts that are available to you electronically and attached to the webinar: the 2018 Employed Surgeon Primer and the 2019 Private Practice Surgeon Primer. And I'd like to ask Dr. Charlie Mabry if he'd care to make a couple of comments about those.
Thanks, Pat. These are two great documents that the college, this is where the fellows' dues goes right into real action. These were designed for the employed surgeon and also for the private practice surgeon. And in those documents, a lot of what you heard from Ms. Cook tonight, a lot of what you heard from Dr. Zinner and Freischlag and Mr. Austin, those are actually already written about in the employed surgeon primer. So you can see those links there, download them. If for some reason you're out somewhere and you forget to download them, you can go to the college website, go under advocacy, and then under practice management, which is a wonderful site for any of those of us either employed or not employed to go to. And there's primers and compendiums, and that's where these are. So any of your friends can go there and download them there for free. It's a great resource for the surgeons.
Great, thanks, Charlie. So Matt, got some questions here that we can start posing to our panelists and to staff.
Of course. I'd like to start off. We've got a couple questions that are clarifications about the earlier part of the presentation related to the support programs. The first question is actually a little bit of confusion over the Medicare grants versus the advanced payments portion. Would you speak a little bit to that and about the and reiterate the recent changes in the advanced payments program?
So the advanced payment program was initiated several weeks ago, and it was basically you would contact your Medicare administrative contractor, and you could receive up to 3 months payment in advance. And then after 120 days, then Medicare would start clawing back what you had received in advance as a repayment. So it was an advance, a loan on future billings to Medicare. As I said, that program has expended $100 billion since its inception, and $40 billion of that went to Part B suppliers, to physicians and others. They abruptly ended that program yesterday morning. We do not know why. Don't know whether or not it will come back or not. But that is no longer an option as we currently stand. The granting program is separate. It comes from HHS through the Public Health and Social Services Emergency Fund, and has now had a total of $175 billion put into it, and they're in the process of dispersing a second round of $20 billion. And based on what we know currently, those who received money starting on April the 10th can go in and attest and accept the terms and conditions for that disbursement, and then will be eligible to then apply for a second disbursement after they have completed their attestation on the terms and conditions.
Great, thank you very much. We have a question here from a bariatric surgeon at a community hospital who asks, My hospital has resumed elective cases, but my critical staff is furloughed, making it difficult for me to restart. What can I do to make them understand that he is unable to do this alone?
One of our hospital panelists care to respond to that?
Well, this is Julie Freischlag. That's really hard. You know, depending on where you are and what your penetration of COVID-19 is with bariatric patients, that's a really hard question. You know, however, it's very important surgery do and great outcomes to where it goes. So I think part of it is I would tell you to go talk to your hospital. You know, talk to the administrators, talk to the people, talk about your program, when it would be safe to make that happen. Similar as vascular surgery, there's some things we do that are urgent emergent, but I'm a thoracic outlet surgeon, and I've got 4 people waiting for surgery, a couple on anticoagulation, you know, and so I think having that conversation about when it's safe, because you don't want a patient to have an operation and end up with a COVID-19 infection, and you also want to make sure those that go ahead are those that are urgent emergent. We have a team of surgeons that are working on how we should do this. Wayne Meredith is my chair of surgery here. So I would get involved and make sure you get your voice heard about timing and appropriateness.
So this is Mike Zinner. So I co-chair a system-wide committee that is trying to establish policies about how we do reopen and who do we open with and in what order. Because there are going to be a whole lot of these kind of issues that come up over the next several months. And I'd say maybe you could help with your hospital organize such a committee in terms of prioritization of ambulatory first and then ambulatory hospital second, and then, you know, more complex surgery. But, you know, what you brought up is a very important point, and I think it does require cooperation with your hospital at multiple levels.
Great, thank you.
All right, Matt, what else we got?
We have an interesting question here from a solo practitioner who applied for the PPP loan and was told by the lender that they only qualified for a fraction of what they originally applied for. I know we had heard from a number of folks who only were told that they were approved, but the funds had run out. The question is, has anyone else heard of cases like this where they were not approved for the full amount, and if there's any kind of recourse?
Yeah, my best advice on that is to go back to your lender and to query them about you know, why you did not think that you qualified for as much as you did, based on the fact that this program is run by the Small Business Administration through your local SBA lender. They should be able to explain that to you. I think it's important to note here that we do know of many folks who went through the process of applying for these paycheck protection loans and were told that their applications did not move far enough in the process before the funds ran out. And it's our understanding that you do not have to start from square one if that has happened to you, that your paperwork and everything that you filled out should stand you in good stead to move forward now that the program has been replenished with funds.
Great, thank you. We have a couple questions relating to telemedicine for postoperative visits. One question is whether or not telemedicine postoperative visits are allowed under Medicare, and another as to whether or not we believe the new telemedicine rules will be made permanent.
Anita, you want to provide us some insight on that one?
Sure. To the first question, there is nothing in the Medicare guidelines that prohibits telemedicine for being done for post-op visits. And definitely right now, it can be done because the telemedicine waivers have been implemented to really expand the use of telemedicine. As far as and that's mainly because post-op visits don't require documentation. So there's nothing that prohibits that. As far as whether the waivers will stay in place, that's unclear. The way that the language is written now, they're only going to be in place for the extent of the public health emergency. But whether CMS will change their mind and somehow retain parts of the expansion of telemedicine, we're not sure about that. I will let everyone know that ACS is on the brink of going live with the telemedicine resource on our website, and that's going to be included in the newsletter hopefully tomorrow. So look there for more information, and please reach out to us with more questions.
As far as a patient satisfier, I think this is where we're going to go. I mean, even though the coronavirus has been a total distractor and emotionally depleting and awful, I do think the post-op visit, especially if they're doing well, can be replaced and actually is a crowd pleaser, especially if your patients are coming from far away. I know I've actually had communication with international patients post-op that weren't even regulated because they couldn't come back to see me. I am hoping that one of the things that we may look back to is that the telehealth piece of surgery can be changed, that we don't have lots of patients waiting in our waiting rooms who are doing fine, that we actually can see all those patients online and perhaps even get paid for them even outside our 90-day window. But I do think there's an opportunity here to change our practice.
I think this is the only good thing that's going to come out of this virus experience is the telehealth part of it. And the only hard part of that is going to be how we're going to get paid for it.
Absolutely.
Matt, I think we got time for one, perhaps two more.
Okay, we've actually had several questions around the concept of whether or not employed surgeons can apply for these things on their own, whether or not employees are entitled to any of the funds that are received by the employer, and whether or not someone who recently left employment should request funds from their previous employer. Can we go over that again to try and get a little clarity?
So why don't you, let's break that down. So give me one of the components there, and then we'll take it from there.
Sure. The earliest question was, as an employed surgeon, whether or not they should be applying for federal programs on their own, or if that is up to the employer.
Yeah, I think, and we can let others chime in on this, if you're an employed surgeon, you're not going to be eligible to apply for the Paycheck Protection Program or the EIDL program. In addition, your employer should be receiving funds from the Public Health and Social Services Emergency Fund if all of your billing is done through their TIN. And they would have to also be the ones who would have requested funds from the Medicare Advanced Payments Program if you are an employee, not something that you would be able to request on your own. Interested if any others on the call have any other thoughts?
Hey, Pat, this is Mabry. One small addendum to that. Some surgeons that are employed are actually employed as contract employees. So they may have their own LLC or their own PA, professional corporation. And under those circumstances, since the corporation actually employs the surgeon and there's a contract between their corporation and the hospital that employs that surgeon, under those circumstances, you can apply for the PPE program, and get funds to cover the salary of the employee, which happens to be the surgeon and any other employees of their corporation.
Great. Thanks, Charlie, for that clarification. That's an important point that I missed. Matt, let's take one more.
Sorry about that, was on mute. We have a question here about basically about the tough decisions that hospital administrators are going to have to be making moving forward, both in the current federal programs, but also as things move forward about ACS and other programs. Would any of the panelists care to speak about how the current situation is going to affect these decisions moving forward?
Mike, I think the folks on this call ought to be in a multidisciplinary committee or commission with the hospitals about how, in fact, you are going to reopen and how you are going to staff in the future, and where, in fact, you are going to put some of the resources. Now, not all hospital administrators are going to be able to do that collaboratively, but that's the only way we're going to be able to move forward.
Right. And I would say exactly the same. If you're not on a committee or being part of the solution, I would go do that, because we really want you all involved. We want to hear from you, not only about how to get the cases going, what's important with quality, what's important with what the college has done, is what other things we do. I think a lot of questions are going to come up about travel and where we can go and can we congregate and what can we do, because we get so much energy from our teams and from the American College of Surgeons. So get involved. Go make an appointment tomorrow. I love talking to those that are on the front line that can tell me what the best things are to do.
Great. Well, I'd like to thank all of you for joining us this evening. This has been a very robust discussion on these issues. We hope that you found benefit to all of the components, and look to get notification from us in the future about our ongoing series of these webinars. And until then, we urge you to stay safe as best that you can, and we wish you good health and good evening.
Thank you.